Welcome back to Cancer is a Mitochondrial Metabolic Disease Basics. Most people have heard of metformin. It is usually thought of as a medication for diabetes. But for many years, researchers have asked whether the same drug that lowers blood sugar could also make the body less supportive of cancer growth. Cancer cells consume enormous amounts of glucose, but glucose is only part of this story. Higher glucose is often accompanied by higher insulin signaling. And insulin is not merely a blood sugar hormone. It can activate the PI3K, AKT, mTOR pathways that tell cells to grow, synthesize proteins, and survive. Metformin may interfere with both sides of this equation, reducing the glucose available as fuel while suppressing insulin and IGF growth signaling. But which matters more? Lowering glucose fuel, lowering insulin and IGF-1 signaling, or the combination of both? Today, we're going to break down the mechanisms. So I'm going to try to take us through a story of how metformin can help fight against cancer. And I'm going to use other literature sources to help make this argument. So let's start with the fact that we know that cancer cells will uptake glucose about 10 to 30 times more than a normal cell. In this publication, it says 20 to 30 times more, and then 30 times more glycolysis or glycolytic rate compared to normal cells. So it is fairly well known that cancer cells are bringing in and utilizing glucose a lot more than normal cells are. Here's a normal cell, kind of a little skinny line here, and a big giant fat line for the cancer cell when it comes to glucose utilization. And one of the things that metformin is most known for is being a drug to treat diabetes, insulin resistance, and hyperglycemia. So if we were to look at, in general, what the total amount of blood glucose that the addition of metformin will get a client or a patient, I pulled this particular paper that was published in February of 2012 because it looked at a total of 35 clinical trials, and it looked at what the average A1C lowering capability of metformin was as a monotherapy compared to placebo, and it was about a 1.12% A1C drop, which is significant. And I pulled this next paper to help illustrate what that actually means in terms of an average blood glucose, because A1C is effectively an average blood glucose for the life of a red blood cell. So what it says here is that every 1% drop in A1C is about a 29 point, in terms of milligrams per deciliter, drop in your average blood glucose. So we can make the simple calculation that the average decrease in A1C of 1.12% would be an average of about 32 milligrams per deciliter and or 1.78 millimoles for those who don't use our same units here in the United States. So effectively, what is happening by lowering blood glucose, whether it be from dietary strategies, from exercise, or in this case, we're talking about metformin, is the cancer cell, and I use arbitrary numbers to make this graphic, but the cancer cell, let's say hypothetically, you have 210 milligrams per deciliter or 11.7 millimoles in the surrounding interstitium or inside the bloodstream. That is going to mean you have about 3 times more fuel to make stuff, whether it be make energy through cytosolic substrate low phosphorylation, whether it be to make stuff through the PPP or the pentose phosphate pathway, or to make stuff through other pathways that actually create raw materials for cancer cells to grow. And you're going to have a lot more lactate because lactate is the end product of glucose fermentation. Now, again, I arbitrarily use the 70 milligrams per deciliter here on this side, but let's say you were to get your blood sugar down to 70, you now have 3 times less available glucose for these cancer cells to use to either make energy or to make stuff as raw materials to grow. And then because there's less glucose for the fermentation process, there would be likely less lactate being created, and there would be less tumor acidification and just a whole host of benefits. So one of the ways that metformin could potentially help a cancer patient, and one of the main mechanisms of how it helps fight cancer, is that it just lowers blood glucose levels. There's less substrate available, then there's less things for the cancer cells to use for energy and to make stuff. But as alluded to in the intro, glucose control or lowering blood glucose is only really part of the mechanism of how metformin can actually help in the fight against cancer. So this paper was published in March of 2015 by Seyfried's group. And effectively, this was the creation of the glucose ketone index tool, the glucose over ketones to give you the degree of how deep you are into ketosis. But I highlighted a little blurb that I thought was fairly fascinating. It says the GKI values of 1.0 or below are considered therapeutic, though therapeutic benefit appears to be associated more with elevated ketone bodies and suppression of insulin than with reduced glucose. So, although lowering the amount of glucose to getting to a cancer cell is important, they believe that being on a ketogenic diet is more so about raising ketones and lowering insulin signaling. And since we're not talking about the ketogenic diet, we're talking about how a potential other mechanism that metformin may have, and that mechanism may be the lowering of insulin and IGF. So I pulled this paper from August of 2020, and it's titled Rethinking the Relationship Between Insulin and Cancer. And it says here, in addition to being a major metabolic hormone, insulin is also a growth factor with mitogenic effects on all cells, more markedly in malignant cells that often overexpress the insulin receptor. In patients with metabolic diseases characterized by hyperinsulinemia, obesity, type 2 diabetes, and metabolic syndrome, the incidence of several cancers are increased, as is cancer-related mortality. Because of the worldwide growing prevalence of metabolic diseases and the diffuse use of insulin and its analogs for treating diabetes, the relationship between insulin and cancer has become a clinically relevant issue. Clinical studies have not clarified the degree to which hyperinsulinemia can influence cancer occurrence and prognosis. To better understand this issue, an improved scientific approach is required with more careful consideration of the mechanisms related to hyperinsulinemia and carcinogenesis. So what effectively is being said here in this paper, or in this abstract, is that insulin is a growth hormone, and it is seemingly even more growth promoting for cancer cells because they will actually overexpress the amount of insulin receptors on their cell surface. So hyperinsulinemia is a very important piece of cancer growth. This next paper was published in March of 2022. It's titled Insulin and Cancer, a Tangled Web. And it says, for a century, since the pioneering work of Otto Warburg, the interwoven relationship between metabolism and cancer has been appreciated. I don't know how appreciated it has actually been. I'm sure there are circles that are very much appreciating it, but the mainstream is not appreciating it much at all. More recently, with obesity rates rising in the US and worldwide, epidemiologic evidence has supported a link between obesity and cancer. A substantial body of work seeks to mechanistically unpack the associations between obesity, ultrametabolism, and cancer. Without question, these relationships are multifactorial and cannot be distilled to a single obesity or metabolism altering hormone, substrate, or factor. I agree with that fully. However, it is important to understand that the hormone-specific associations between metabolism and cancer. Here, we review the links between obesity, metabolic dysregulation, insulin, and cancer with an emphasis on current investigational metabolic adjuncts to standard of care cancer treatments. And kind of one of the more important papers that I wanted to pull, it was published in July of 2017 and was titled The Association Between Hyperinsulinemia and Increased Risk of Cancer Death in Non-Obese and Obese People, a population-based observational study. And it says, among all participants, cancer mortality was significantly higher in those with hyperinsulinemia than those without hyperinsulinemia, with a hazard ratio of about double. You're twice as likely to die of cancer if you have hyperinsulinemia than if you don't have hyperinsulinemia. Similarly, among non-obese participants, multivariable analysis showed that cancer mortality was significantly higher in those with hyperinsulinemia than those without. In this non-obese population, they found there was about a 90% increased risk of death if you have hyperinsulinemia versus not having hyperinsulinemia if you're not obese. So insulin is clearly an important piece of cancer growth, again, but also of more cancer mortality. So the next piece of the story is laid out in this paper in July of 2021, and it's titled Hyperinsulinemia and its Pivotal Role in Aging, Obesity, Type 2 Diabetes, Cardiovascular Disease, and Cancer. And it says here, insulin produced by the pancreas and GH produced in the pituitary gland both stimulate IGF-1 production in the liver. While after secretion, IGF-1 feeds back to suppress both insulin and GH secretion. In healthy individuals, the insulin, GH, IGF IGF-1 axis is in balance. However, where it becomes problematic is when you have hyperinsulinemia. So I pulled out this little blurb of the article where it says the normal balance between insulin, IGF-1, and GH is disturbed in modern societies. And I highlighted this area here where it says hyperinsulinemia per se in turn induces elevated IGF-1 secretion. The elevated IGF-1 sequentially suppresses GH secretion to lower levels than normal. And what we see here is that the feedback loop that is in normal humans is broken in these modern times with metabolic diseases. So insulin is super physiologically increased due to our lifestyles, poor diets, etc. And that increases the IGF-1. And then because IGF-1 is a feedback mechanism for GH, then we lose our growth hormone and insulin keeps coming and insulin keeps coming. So therefore we have high insulin, high IGF-1, and we're now in this very imbalanced situation. Well, there's also relationships between IGF-1 and cancer as well. So this paper was published in May of 2002. Interest in insulin-like growth factors, IGFs, and their effect on carcinogenesis has increased recently because high serum concentrations of IGF-1 are associated with an increased risk of breast, prostate, colorectal, and lung cancers. Physiologically, IGF-1 is a major mediator of the effects of the growth hormone. It thus has a strong on cell proliferation and differentiation and is a potent inhibitor of apoptosis or programmed cell death. The actions of IGF-1 is predominantly mediated through the IGF-1 receptor. The IGF-1 receptor is involved in several oncologic transformation processes. The ability of unbound IGF to interact with the IGF-1 receptor is modulated through the IGF binding proteins 1 through 6. IGF binding proteins, especially IGF binding protein 3, has independent effects on cell growth. For example, IGF-BP3 has pro-apoptotic activities, both dependent and independent of PPD3. And I pulled this graphic here, or this next paper from 2015. It says insulin-like growth factor system in cancer in novel targeted therapies. And in this abstract, it says insulin-like growth factor, IGFs, are essential for growth and survival that suppress apoptosis and promote cell cycle progression, angiogenesis, the making of new blood vessels, and metastatic activities in various cancers. The IGF's actions are mediated through IGF receptors that are involved in cell transformation and induced by tumor. These effects depend on the bioavailability of IGFs, which is regulated by IGF binding proteins. We describe here the role of IGF system in cancer, proposing new strategies targeting the system. We have attempted to expand the general viewpoint of IGF-1R, its inhibitors, potential limitations of IGF-1R antibodies, and tyrosine kinase inhibitors, and IGF-BP actions. This review discusses the emerging view that blocking IGF via IGF-BP is a better option than blocking IGF receptors. This can lead to development of novel cancer strategies. And basically, one of the reasons I pulled this is because it was a more modern paper, but it was also had a nice graphic here showing how IGF signaling is related to survival of cancer, proliferation of cancer, metastases or metastatic spread of cancer, and metabolic reprogramming and metabolic changes. So IGF-1 is also a big piece of this story. So to summarize this, when we have higher amounts of blood glucose, we have higher amounts of insulin, and we have higher amounts of insulin-like growth factor 1, which doesn't just translate into more fuel availability. It also translates to increasing these signaling pathways, specifically this PI3K, AKT, mTOR pathway, which leads to activation of these growth and proliferation pathways that allow cancer cells to grow, metastasize, survive. So part of the reason why metformin could be helping us is also through lowering of IGF-1. So I'm going to finally get to this paper that is being set up here after all of that. And that was published in May of 2022 and was titled Metformin and Cancer, an Ambiguous Relationship. And that's a play on words instead of ambiguous. And these are biguanides. So in the abstract, it says the deregulation of energetic and cellular metabolism is a signature of cancer cells. Thus, drug targeting cancer cell metabolism may have promising therapeutic potential. Previous reports demonstrate that the widely used normoglycemic agent, metformin, can decrease the risk of cancer in type 2 diabetics and inhibit cell growth in various cancers, including pancreatic, colon, prostate, ovarian, and breast cancer. While metformin is a known adenosine monophosphate activated protein kinase, AMPK, agonist and an inhibitor of the electron transport chain complex 1, we'll talk about that in the second part of this metformin series. Its mechanism of action in cancer cells, as well as the effect on cancer metabolism, is not clearly established. In this review, we'll give an update on the role of metformin as an anti-tumor agent and detail relevant evidence on the potential use and mechanism of action of metformin in cancer, analyzing antitumoral, signaling, and metabolic impacts of metformin on cancer cells may provide promising new therapeutic strategies in oncology. And what it says here is that the history of the biguanide metformin is linked to Galega officinalis, also known as the French lilac or Italian fitch. Galega officinalis represents a traditional herbal medicine that was found to lower blood glucose in 1918. Guanidine derivatives were used to treat diabetes mellitus in the 1920s and 30s, but with the availability of insulin, were discontinued due to their toxicity. During World War II and throughout the search for antimalarial agents, metformin was rediscovered and determined to lower blood glucose levels. The French physicist John Stern was the first to report the use of metformin to treat diabetes mellitus in 1957 and named the compound glucophage, which means glucose eater. Since its introduction, metformin has become the most prescribed glucose-lowering drug worldwide. Metformin in cancer. To date, there are over 50 recent or active clinical trials investigating the use of metformin for inhuman malignancies. Total daily dose for oral metformin in these clinical trials ranged from 500 to 3,000 milligrams. This range reflects the previously established drug dosing used to treat patients with type 2 diabetes with gastrointestinal toxicity limiting beyond its use of 2,500 milligrams per day. That's why most physicians are not going to use more than 2,000 milligrams per day. Matter of fact, I don't think I've actually ever seen a patient get more than 2,000 milligrams per day clinically, even though it seems like it has safety up to 3,000 per day. In future clinical trials, we suggest aiming to achieve the maximum tolerated dose of 2,500 milligrams per day, given the majority of preclinical studies required high concentration of metformin to achieve anti-cancer activity. Furthermore, we recommend planned dose escalation to allow for GI habituation, as well as allowance of dose interruptions and reductions for drug toxicity to reflect real-world practices. And we're only going to go over the piece of metformin's beneficial activities on what has been presented so far. So basically, what we've presented so far is that metformin is a known AMPK activator, and that is going to, in a couple of different mechanisms, lower blood glucose, and it's going to indirectly lower blood insulin levels because less blood glucose, less insulin. So these are the two kind of more classical mechanisms of how metformin help in the fight for cancer by lowering blood glucose, blood insulin, and IGF-1 levels to remove substrate as well as signaling cascades that are pro-growth, pro-metastases, pro-progression. In the next video, I want to talk about some other unique mechanisms that metformin and that family of medications may have that may also additionally help in the fight against cancer. And it has to do with the electron transport chain. If you like videos like this, please like, share, and until next time.